So we've just about reached peak phone. In developed countries, over 85% of people have a smartphone. I'm looking around the room and there are a few people who may fall into the category, and I say this respectfully, of silver surfers. So when people say to me, well, look, older people don't have phones, that is no longer true. 35% of Australians pick up their smartphone within 5 minutes of waking up. 46% play with it 15 minutes before they go to bed, even though they know the blue light is going to disrupt their sleep. And the best data we have suggests that on average, Australians pick up their phone 35 times each day and use it for a cumulative 2 hours. I've got to say that the screen time addition to the Apple suite has really made me look carefully at what I am doing, because I am so addicted I have to carry one on my wrist. So when you're thinking about apps in healthcare, they can be for people to manage their own health or for us health professionals to help us in our job. Now, the average Australian smartphone has about 100 apps on it. You know, it looks good, I'm going to download it. We actually use, on average, about 10 a day and maybe 35 a month. So there's something interesting going on here, that we see the potential, but we actually only end up using things regularly that are really useful to us. Now, there was mention before about a disconnect between what's happening in healthcare and in industry. And I tell you, industry is super interested in health apps. This is a growth category, and we're going to see more and more work in this space. And if you go to apple.com and search around, you can find a space where they talk about health apps, and you can find these like amazing concepts where you're going to have this ecosystem and your Apple Watch will record your biometric data. And when you have your seizure, you then can indicate you've had a seizure and you'll get a questionnaire to capture data at that time, which then goes to the app on your phone where you can self-monitor, figure out patterns, gain some insights, and your data also goes to presumably ethical and moral doctors at Johns Hopkins, and they can find out how to help people with epilepsy. So these are the kind of ecosystems that are beginning to emerge. Now, I often ask questions in my lecture, and the medical students look to see if I've got the chocolates with me today. No chocolates, folks. But who can tell me what the 29th of June 2007 was? Oh, come on, someone must know. I'm wearing a black turtleneck. I'm kind of little and really excited. So, no, this is when Steve Jobs announced the first iPhone, okay? So that is not even 12 years ago. So would you be surprised that I would tell you that the literature around apps is a kind of hot, happy, jumbled kind of place to play? When you've only got 10 minutes, it's pretty hard to give you a lot of data or information about a big, messy, happy literature. So what I've tried to do, and this is just my own thinking, is help you navigate what is out there, and then I'm going to tell you how we really have to change everything we're doing. So I think of the app literature in 4 main areas. There's literature that focuses very much on one app or groups of apps. There's literature that focuses on people and how they use apps. There's literature on implementation, and then there's a little bit of literature on outcomes. And let's face it, that's what we're really interested in, although the others all inform the last. So what's the main literature on individual apps? So there's a body of literature about development. We had this idea, we got some stakeholders involved, we did some testing, and we made this thing. There's literature on types of apps in a certain category. What kind of apps are there for self-managing epilepsy? What kind of apps are there for managing chronic pain? And then there's this really interesting and very messy literature on app reviews, which are things that, to a greater, often, and sometimes lesser degree, look a little bit like a systematic literature review, but done in the app stores. So I've just got a couple of examples. So, you'll have to forgive me that there's a little bit of a rheumatology lens on all these. So, University of New South Wales, in collaboration with Macquarie University and a rheumatologist in Sydney that you may know, Rick Day, have got a program of work exploring how people with gout could better self-manage assisted by apps. And one of their early pieces of work was getting focus groups of people, predominantly men with gout, to look at the apps that were currently available and say, well, what's good about them? What could be better? How would this help me? What barriers would there be to me using this? And then they got a beta version of an app to have a play with to see if they can improve that. This work's now progressed to have an NHMRC funded randomised cluster controlled trial happening in primary care in Sydney. So this is one example of early app development literature. Now, I have done, or perhaps am guilty of doing, one of these systematic app reviews, which I look back and think, gosh, I could have been more systematic. But hey, I was interested if people with rheumatoid arthritis could have an app to help them manage their own rheumatoid arthritis, largely because there's not enough of me and we can't see people at appropriate intervals. So I looked with a few med students at the iTunes and Google stores, and we found 19 apps that met our fairly strict criteria. And when we looked through them, after operationalising the best practice measurements that you would do in someone with rheumatoid arthritis, we found one of those 19 apps that was sort of okay. It had bits of what we needed, but certainly not everything. We also discovered some interesting things about the apps that did exist, and I'll just illustrate this for you about some of the problems that do arise. So you can see closest to me on the left, there's a little homunculus. What you probably can't see is it's got little dots, which is where people with rheumatoid arthritis could self-report their data. Now, no rheumatologists in the room, but I'm guaranteed you all know there is no synovial joint right here that a person with rheumatoid arthritis needs to report tenderness or pain on. The second example with the hand is quite a nice design feature. You know, there's one joint and you tap on it and you get 4 options. There, nothing's wrong, both's wrong, I've got pain, yep, we're doing okay so far. And then the fourth option is inflammation. Now, what does inflammation mean? I know what it means to me. It means to me as a rheumatologist that they've either got tenderness or a swollen joint. But what does inflammation mean? So we're collecting data here that I can't translate into anything meaningful. The last example is kind of interesting. It's an X-ray of a hand with some overlaid points with all the, thank you, correct joints and all the correct concepts, pain, tenderness and swelling. But when I've done some stakeholder engagement with patients, they find this frankly creepy. The other problem with this is if you just imagine that's on your phone and you're trying to translate your hand into this, people can't figure out which joint's which and get the wrong hand. So there's some good stuff out there, but it's not really fit for purpose. I've grouped these two together because they sort of overlap. Who uses apps, how do they use them, their attitudes, their knowledge about apps, and then implementation, which could be user experience, use over time, pitfalls, and even workflows. So one thing we don't know a great deal about at a population basis is who uses apps and what they use them for. There are some large, rather better quality population-based studies, 2 in the US and 1 in Germany, which have gone out and asked, do you use apps? Do you have a smartphone and do you use apps? And as we move from left to right, we've got US, Germany and US again. And what you can see is the proportion of people who have smartphones has quite understandably gone up. And interestingly, the early studies had really a minority of people using health apps, and most of these were just like Babylon, young healthy people who probably were already in very good health. The most recent study divided people by a diagnosis of self-reported hypertension, and interestingly, people who had this chronic condition did report slightly higher use of health apps, so perhaps this initial pattern is changing. Now, whenever I talk about apps, I always have to talk about this because the app in the study has just got the best name ever. Cloudy with a chance of pain. Great play on words. So this is a group led by Professor Will Dixon at University of Manchester, who are exploring the day-to-day reality of rheumatology practice, which is somewhere in your day, one patient is going to tell you that it rained last week and I got really stiff and sore, or the better weather, I'm going to be good, doctor. So this is an amazing crowd-sourced research where this app has been set free, and anyone in the UK who wants to download it who has self-reported pain or arthritis. And what they can do is, with whichever frequency they like, do a number of validated questionnaires about their pain and fatigue, and it will geolocate the local weather. And this is a massive data set which is going to explore the relationship between people's symptoms and the weather. I talk about it because it's so cool, but the other thing I just highlight from this is they've got very good data about how people use this over time. And the green lines in that graph are people who log every day, which will be really useful because we'll get this highly, highly granular data. And that's just the first 8 weeks of use. So what you'll see is most people download it and put something in, but over time the red goes up, which is people only logging a couple of times a week. Interestingly, there must be some real digital converts, because at 6 months, 1 in 7 people were still tracking every day. But that's an interesting take home, that there's always going to be this little group who really embrace this. If you're putting this into a healthcare setting, that's good for them. But what happens to the rest? We really get down to the nitty-gritty on app outcomes. Now, many of these are single-centre local implementation studies, but there's an emerging corpus of randomised controlled trials. One of the problems with them is by the time they get published, the technology's gone. Some of the best studies in smoking cessation are text messaging, which is, 2010 or something. There are some metasyntheses coming out which give us a more evened out view. And just recently, there's been a metasynthesis of randomised controlled trials at a massive public health problem, diabetes. These were apps for adults with diabetes where there was a behavioural change component in the app, which is really, really important. The comparison in all these studies was usual care. Now, there is a massive source of bias because there's something fundamentally different about having this fancy thing on your cool phone and just doing what you normally do. So we'll just keep that there. Now, in the 5 studies of type 1 diabetes, there was a small reduction and a good outcome, although a surrogate, of HbA1c, but it wasn't significant. Now, that's not necessarily surprising when you think about usual care for these people. What's more interesting is, on average, all the forest plot there illustrates that all the studies in type 2 diabetes were on the positive side, that the app improved their HbA1c, and it was about negative 3.5. Now, you think about that and you wonder, well, is that really clinically significant? At the individual level, it might not be, but at a population level, I think there's promise there. Now, if we look at the future, I've taken you through the hot mess, and we really need to think about what we could do better. So an app is individual focus and the health and looking at the consumer or patient, and the health system looks at us, and we need those things to connect better. We need to have an emphasis on the people who are using it and involve them in the design process, and we have a tendency to over-engineer things till they're perfect. We probably need new ways to evaluate health service improvement, because with failing fast and not needing the large randomised controlled trial, which is kind of redundant in technology by the time it's finished. We need more flexible approaches to software in clinical settings, but with safety nets so we don't make dangerous mistakes. And the other thing, amongst a group of doctors, I'm always hesitant to mention this, but we need new business models, because if we're going to do this, what are we not going to do, and how are we going to account for that cost? So we do need to get more savvy and think how our managers think. So I'll leave you with those challenges, but I hope I've sparked your interest in this emerging area.